Hello, everyone. Welcome to this live stream sponsored by Medscape Education. And this is actually supported by an independent education grant from Bayer. My name is Nick Kim. I'm professor of medicine and director of pulmonary vascular medicine at the University of California, San Diego. It's really my great pleasure to have with me Dr. Marc Humbert. He's professor of medicine at the Université Paris-Saclay, French Pulmonary Hypertension Reference Center in La Kremlin-Bicêtre in France. He wears many hats. He's obviously a world expert in pulmonary hypertension, including CTEPH, so it's my pleasure to have him with us. We're going to spend the next 15 minutes or so talking about some real-world insights into chronic thromboembolic pulmonary hypertension. So with that, I'm going to ask Professor Humbert to kind of give us an introduction to this condition. Marc?
Thank you. Thank you very much, Nick. It's a great pleasure to be with you today. So chronic thromboembolic pulmonary disease, in fact, describes patients who are short of breath and who have mismatched perfusion defects on ventilation perfusion lung scan with signs of chronic organized fibrotic clots on computed tomography, pulmonary angiography. And these patients show occlusions of the pulmonary arteries with stenosis, webs, total occlusions after at least 3 months of therapeutic anticoagulation. And when you have pulmonary hypertension in that setting, it is not only a consequence of the obstruction of the pulmonary arteries by organized fibrotic clots, but it can be also related to an associated microvascular disease.
Yeah, thank you for that introduction. I think, so the current understanding also is that it's related to pulmonary emboli, and we think roughly, 2 to 3% of patients after submassive PE may develop chronic thromboembolic pulmonary hypertension. I think the viewers should also be aware that traditionally the treatment has been primarily a very complex surgery called pulmonary endarterectomy. This was largely pioneered at UCSD, but also in Paris as well. Marc, maybe you can comment on why this surgery is so difficult and challenging.
Yeah, no, it's a very good point. First, your comment about pulmonary embolism is critical. It's not always symptomatic, and the history may be sometimes difficult, but indeed, it's a consequence of pulmonary embolism. Then, surgery is difficult because it requires real expert surgeons and expert anesthesiology team and expert multidisciplinary team able to identify the patients, characterize them, and also manage them in the acute setting. So this surgery is in fact an endarterectomy performed under cardiac arrest and hypothermia. So it is really a surgery of great importance because it can totally improve the pulmonary vascular impairment, but also it has to be done properly in good hands. So really congratulations on the achievements of the San Diego team. And in Paris, we have followed, and many expert centers in the world have followed. But it's not everyday's business in most centers. You need a real expert center, and you need a high flow volume and a very good multidisciplinary team.
Yeah, I'm glad you mentioned the important, described it as an endarterectomy, because unfortunately I still see or hear colleagues mistaking it for pulmonary thrombectomy or embolectomy. That this is a very different type of surgery for you viewers who are less familiar. And I would say one other thing is these patients, unless you do a perfusion image with the additional testing that Marc mentioned, these patients can look just like pulmonary arterial hypertension. But obviously the treatment is radically different. And regarding the treatment, I think traditionally we focused on surgery as the only option. But to Marc's point, the obstruction can be in the smaller, more distal pulmonary arteries, as well as the microvasculature. And that has opened up potentially other treatment modalities, which we want to talk about. namely balloon pulmonary angioplasty, which was first reported in Europe but refined from our Japanese colleagues. And then medical therapy, namely riociguat, which is the one that's currently FDA and EMA approved. So maybe I'll ask Marc to take us through some recent exciting randomized control data in looking at the role for balloon angioplasty and riociguat, starting with the RAISE study.
Yeah, I will start with the RAISE study. So the RAISE study was a French study we led in my country. It was a multi-center phase 3 open label randomized control trial with an ancillary follow-up study. And in fact, this study was comparing balloon pulmonary angioplasty with medical therapy with riociguat in patients with inoperable chronic thromboembolic pulmonary hypertension. So the first step was to exclude the operable patients because operable patients should be operated. And then these non-operable patients, they were randomized to receive either BPA, balloon pulmonary angioplasty, or riociguat. In fact, the balloon pulmonary angioplasty induces stronger decreases in pulmonary vascular resistance and better hemodynamic improvements, but at the cost of most more common side effects, such as hemoptysis or lung injury. So the beauty of this study that it was followed by an ancillary study for the people with persistent pulmonary hypertension. The other approach was proposed. Those who started with BPA, if they had persistent pulmonary hypertension, they were offered riociguat and vice versa. And when you start the BPA procedure with a lower pulmonary vascular resistance and a lower mean PAP, it induced less hemoptysis and less lung injury. So for this study, stronger impact on PVR, but with more side effects. And second line BPA after riociguat was safer. Maybe you want to comment on Mr. BPA, the Japanese study?
Yes, no, congratulations, by the way, on the RAISE study. I think this has really changed how we approach inoperable patients, especially those with severe hemodynamics. The Japanese study, Mr. BPA, was published alongside the RAISE study, and they took basically balloon angioplasty and pitted it against riociguat, and they looked at mean PAP change after 1 year. Now, you have to remember, first is a mechanical treatment and the other is a medical treatment. And what they found, not surprisingly, is that you have bigger impact in lowering the mean PAP by balloon angioplasty first line compared to riociguat. However, like the RAISE study demonstrated, there was a higher complication rate if you go first line BPA versus first line riociguat. So I think these two studies really complement each other and has made its way onto treatment algorithms. So I'm going to ask the lead author of the most latest European guidelines in pulmonary hypertension, a magnificent piece of work, which also included discussion on chronic thromboembolic pulmonary disease.
Thank you. Thank you, Nick. So indeed, the European guidelines propose the treatment algorithm for CTEPH, for chronic thromboembolic pulmonary hypertension. So a few comments on this algorithm. First, the lifelong therapeutic anticoagulation should not be forgotten. Second, the multidisciplinary team assessment should be highlighted, underscored, and certainly good quality imaging, good quality clinical and hemodynamic evaluation, and an excellent medical and surgical eye. And the operable patients should be operated unless contraindication exists. And if the patients are not operable, and if they have subsegmental disease, the patients should be considered for medical therapy and or balloon pulmonary angioplasty. So the important message from that algorithm is that it's always based on evidence, and there was more evidence, of course, from randomized control trial with the medical therapy, and the RAISE and Mr. BPA suggest that it might be wise for patients with severe pulmonary hypertension and chronic thromboembolic pulmonary disease to lower the mean PAP and offer BPA after lowering the mean PAP. I will hand over to you to comment maybe more on more recent algorithm.
Thank you. The slides look somewhat different, but actually the content is quite similar. And I think what we did in the World Symposia, which was published earlier this year, it's an event that happens every 5 years in pulmonary hypertension, including chronic thromboembolic disease. We emphasize the role for the multidisciplinary team. Again, this is a disease now no longer just relegated to expert surgical centers able to do this complex surgery, but we need both the surgical team, balloon angioplasty team, as well as the pulmonary hypertension experts capable of delivering real SigWat and other treatments. And on top of that, you need chest radiologists who are trained at the subtle features of chronic thromboembolic pulmonary hypertension. The other thing I want to highlight is the importance of follow-up, a structured follow-up, which was also mentioned in your guidelines, Marc. And we recommended in our expert panel 3 to 6 months after to reevaluate and perhaps kick it back to the multidisciplinary team, because you can actually have patients who undergo surgery who end up needing medical therapy and balloon angioplasty. For the last few minutes, I want to share with you some exciting recent news on the RealWorld Registry. This is the publication led by Marianne Delcroix, International CTEPH Association. Over 1,000 patients with CTEPH who were enrolled in this prospective registry from 2015 to 2017 with follow-up, or 16, and with follow-up for 3 years. And roughly about over 1,000 patients are represented here. And these are patients enrolled from Europe, Japan, as well as Americas. And about 60% of these patients actually underwent endarterectomy surgery. 18% ended up with balloon pulmonary angioplasty. And there was unfortunately 22% of patients who were deemed neither candidates for either intervention. And I want to show you some data here. So these are hemodynamics that were available in long-term follow-up. And if you look at the endarterectomy and balloon angioplasty group, at the end of the day, they had similar PVR reduction. I would say the key difference here is that majority of balloon angioplasty patients were still on pulmonary hypertension therapies like real SigWat. And you see a lesser impact in PVR lowering if you just go with medical therapy. And the key result is shared in this following slide of the survival. You can share that, please. So this is the Kaplan-Meier survival curve. In the blue were patients who were treated with endarterectomy. In the red who were inoperable, treated with balloon pulmonary angioplasty. And in the green, these are patients who had neither intervention. And you can see their survival was much worse than the other two intervention group. So Marc, I think one of the key takeaway messages now for CTEPH management is you really need to have one of these two interventions, either at a skilled surgical center if they're deemed operable, or a specialized center with balloon angioplasty. I also lastly want to comment, BPA is no longer an experimental therapy. When I hear this, Marc, I always correct them. That's not experimental. This isn't something that we want many centers to experiment with, but it's an established treatment. And hopefully if you follow the guidelines and these evidence, you can have the similar kind of great outcomes for your patients.
Yeah, I think it's outstanding to see how this dramatic disease has improved over time thanks to interventions allowing deocclusion of the vessel. So irrespective of the technique you use, it depends on the proximal or distal disease. What matters is really to deobstruct the vessel. So thank you to the World Registry to emphasize that.
Thank you. And I think we still have many other questions to tackle, like, which strategy, what combination, and how do we, reassess after treatment and they have still persistent disease. And you also pointed out some patients don't have pulmonary hypertension at rest. And how do we tackle those patients? So thankfully, the field has still a lot of work still remaining. So with that, I think we're at the end of our 15 minutes. I want to thank Marc for joining and also for the viewers for tuning in. Thank you very much and have a good day.
Thank you.